our dear Professor Hassan Maghrabi, for organizing this very magnificent presentation. And before passing into my presentation, I would announce it's an honor for the EFRI to announce its first online educational course about infertility. The course will be conducted over 16 presentations, which will discuss the different topic of infertility in a comprehensive manner. And the lectures will be delivered by eminent specialists in the field of infertility from Egypt, England, and Canada. And all of you are invited to participate. Our secretary, Mrs. Salah, whose contact will appear on the attachment side of the webinar. My title of presentation is "When Should the Gynecologist Make a U-turn during the infertility management?" The term U-turn was firstly used in USA in 1925 for regulation of the traffics, and it means that the passenger, the traveler, will go 180 degrees to the reverse direction of its journey. However, symbolically, it can be used in the different branches of life, and it includes reversal or a change of the person's strategy, plan, behavior, and attitude. Every journey has its start and its final destination. If we look, what are our targeted destination during an infertility journey? Sure, it is the take-home baby. And this targeted or final destination can be reached through different routes. But the ideal route is that it should be associated with the least time, with the least psychological stress for the couples, and with the least financial burden for these couples. The instruments which are used during an infertility journey are three. The first is the vehicle, which is the patient. The second is the driver, who is the gynecologist, and the third is the road, which is the treatment plan that's proposed by the gynecologist and should be followed by the patient. Every one of these should have a certain characteristics in order to reach safely for targeted. The patient should have some patience. The instruments which are used during the infertility journey are three. The first is the patients, the second is the gynecologist, and the third is the treatment plan. The patient should have some patience during the journey, and the gynecologist should be honest and vigilant. And lastly, the treatment plan should be as much as we can evidence-based. Actually, the field of infertility itself is very paradoxical and exotic in two main reasons. Firstly, the patients are highly vulnerable for abuse, and the second, it is the only branch of medicine which may set a failure rate which may reach up to 60 or more percentage of failure rate. It's to be stressed that the treatment plan, which is posed by the gynecologist, is not a holy one. It's dynamic. And the term dynamic is not a redundant one. It's not left according to the passion of the health provider, but it is governed and regulated by the guidelines and the borders provided by the evidence base. In many occasions, the driver or the gynecologist may lose his road during management of infertile couple, and this is due to three main reasons. The first is carelessness, and carelessness is considered as a kind of medical negligence. The second reason is lack of knowledge, and today lack of knowledge is not considered as a reason due to the easy availability of information through the different media. So once again, it's considered as a kind of negligence. The third unfortunate reason is the financial temptation by the gynecologist. Let us to narrate the story of the unfortunate Mrs. Suzanne. During this story, we can see which U-turn that the gynecologist should obey. She is an elegant 24-year-old lady. She has a primary infertility of 1 year duration. She has a normal menstrual pattern. She's was regularly ovulating, normal semen analysis, normal histoscopy, and normal transvaginal sonography. She does not have history of previous surgery before, current or previous history of pelvic infection, and didn't have manifestations suggestive of endometriosis. A gynecologist prescribed clomiphene citrate for 3 months, followed by gonadotropin for another 3 months. But she failed to conceive, and he advised her to continue with gonadotropin. What do you think about the interventions? Is that it's okay, or should the gynecologist make a U-turn? I think this issue has been discussed in the elegant presentation of Dr. Dracopoulos, who stated that expectant management in young women should be practiced for at least 2 years, and during 2 years, you should anticipate a high pregnancy rate. But it's to be emphasized again, the behavior or the intervention of this gynecologist is not totally abnormal. And one study shows that about 1/3 of the patients might be exposed to unnecessary early intervention. And one important reason for this early intervention is refusal of the couple to continue or to pass into expectant treatment. So, as the situation, what should be the solution? Either we would try to convince them with expectant treatment or to go with intervention. However, some clinicians have introduced what's called forget expectant treatment. The forget expectant treatment, they try to reach a compromise. They give the patient specific medications like antioxidants, like mitochondrial stabilizers, or in the second half of the cycle in order just to ameliorate anxiety and give the nature time to do its work. However, this strategy has been criticized. It doesn't have any scientific rationale, and it appears a great ethical concern. Whether there is any role of ovulation induction in that young lady after 1 year of infertility, I think, again, this was discussed by Dr. Dracopoulos. 1 year later, now we are coming again to the story. After 1 year, she has infertility of 2 years duration. She visited another gynecologist who directed her towards laparoscopy. Now she is about 26 years old, 2 years infertility, and she undergo at that station. The opponents of laparoscopy have many arguments, and many studies indicated that in women with normal histoscopy or even unilateral tubal pathology with histoscopy, the laparoscopy, if it is done, will never cause a change of the plan of the treatment plan in more than 95% of these patients. Another study concluded that after good history taking with normal histoscopy and single transvaginal sonography conducted by experienced hand, it could eliminate unnecessary laparoscopy in about 90% of these women. A very interesting study showed that in women with normal histoscopy, no evidence of endometriosis, PID, or pelvic surgery, there was no increase of the pregnancy rate if the laparoscopy was done followed by induction on one side, or if ovulation induction was done without performing laparoscopy. This denotes that the laparoscopy has a minor role. So, in order to cut this last of the ASRM in 2015 concluded that routine laparoscopy is not recommended in young women without evident pelvic pathology. However, after 3 years of infertility, it could be indicated. And I am asking you to do what's called coin flipping test before performing laparoscopy. Okay, and after taking a history, and according to the circumstances of the patient, speculate. Yes, in more than 90% of the cases, your speculation will be correct. So, in a majority of patients, you know that whether the laparoscopy is will be normal or abnormal. And in this case, your job will be just to drill the abdomen and to receive fund. Whatever, the unfortunate Mrs. Suzanne underwent laparoscopy and it was completely free apart from bilateral hydatid of Morgagni that were overlooked by the surgeon. What do you think? Whether he should take a U-turn or proceed? All of us know the hydatid of Morgagni. Before going to this issue, I would ask to you, if you have found this band of adhesion below the ovary during laparoscopy, whether you remove it or will leave, I think most of us will leave it. If you found a band of thin adhesion pulling the fallopian tube away from the ovary, you will leave it or will you release it? I think most of us will release it. So why this is not coming with the hydatid of Morgagni, which is it's highly prevalent in women with unexplained infertility. And many studies concluded that their removal was associated with a significant increase in the pregnancy rate in women with unexplained infertility, particularly if these hydatid of Morgagni were associated with the three characters. If there were bilateral, if there were fimbrial, and if there were more than 2 centimeters in diameter, which can be easily assessed by the laparoscopic probe. Whatever, they were overlooked by the gynecologist. After 8 months, the unfortunate Suzanne received the clomiphene to complete the diagnostic infertility workup. What do you think? Should the gynecologist proceed to his hysteroscopy or should he make a use and the removal may increase the pregnancy rate? Yes, it is true, but this is with evident uterine pathology. The main problem, the main problem is with subtle uterine abnormalities, like a virus. During the last year, a very interesting study has been published about the substitute uterus, which concluded that the overdiagnosis, overscreening, and this unnecessary may be harmful for the patient that should be kept silent in place. Another very, if we have looked for this very exciting figure, these are 20 women. If they have been assigned according to the ESHRI diagnostic procedure, the diagnostic criteria for substitute uterus, or called the European uteri 20 as having a substitute uterus. On the other hand, if you have used the ASRM criteria, 1 woman among these 20 women to have a substitute uterus. A very interesting published by the Center of Human Reproduction from New York about the decline in the pregnancy rate following IVF during the last years. And they have provided many factors which are responsible about that. And personally, I speculate that the routine use of hysteroscopy may be one factor responsible for this decrease. And I have more recent arguments about 2 recent studies, one in the last year which shows that the endometrial pregnancy rate, and they tried to do endometrial scratching during the follicular phase, but this study was prematurely terminated because of the very high rate of miscarriage if the endometrial scratching was done during the follicular phase. In order to conclude, all the societies concluded that routine hysteroscopy is not indicated unless posed during natural cycle and before IVF unless it is clinically indicated. Whatever, the Mrs. Suzanne underwent hysteroscopy, which revealed a small septum as claimed by the gynecologist that was resected. But years ago, she had 5 years infertility and she was enrolled into an EXI program. What do you think? Should the gynecologist proceed directly or should he take it as Dr. This is also stated by the last ASRM recommendation, IUI should be practiced is usually the first line treatment of successful pregnancy have the right to undergo IUI before IVF. She underwent an exit program and she was ranked as a normal responder according to the sonography and AMH. And she was assigned as Poseidon Group 1. So the Longo protocol was used and induction was done with 225 international units of HMG. On day 7, she has 6 follicles, about 8 millimeter in diameter, and the E2 was 170 picogram. The gonadotropin dose was increased to 300 per day, and on day 15, she has 6 follicles, about 17 millimeter. HCG was given. She yielded just 3 oocytes. From that, only 1 embryo was obtained, which was transferred on day 3. But unfortunately, the serum beta HCG was negative. What do you think regarding the management of this lady during this stage? It's okay, or he should make a U-turn? These women are called as unexpected poor ovarian response. That's the ovarian reserve is diagnosed as normal, but the oocyte yield is suboptimal. And there are 4 main reasons behind this phenomenon. The first is an inadequate gonadotropin dose. The second is hostile ovarian environment, mainly disturbance of the androgen. The third is follicular asynchrony. And the last reason is polymorphism of the FSH gene. Whether we have an option during this current cycle or not, there are a very important dictum regarding this patient. The more oocyte, the better, and just 1 more oocyte is matter. Yes, this is particularly valid in these patients. And we have 2 studies reported that 1 extra oocyte increases the pregnancy rate in this woman by 5 to 25%, or even increase the live birth rate. During the current cycle, the gynecologist has only 1 of 2 choices, either to increase the dose of gonadotropin, which has been conducted by the gynecologist, but a dose of more than 300 international units per day is unnecessary. The second is to introduce recombinant LH during the 7th day of the cycle. 5 months, unfortunately, Suzanne enrolled into another trial. She received DHA, mitochondrial stabilizers, and the antioxidants for 2 months before induction, and combined oral contraceptive pills was used in the preceding cycle. The stimulation, the gonadotropin was a combination of recombinant FSH 300, human menopausal gonadotropin 75 together with 150 units of recombinant LH. On day 6, the antagonist was used. On day 12, she has 5 follicles, and GnRH agonist was used to trigger ovulation. She yielded just 2 oocytes. Then stimulation was continued during the luteal phase, yielding 5 extra oocytes. But unfortunately, she has just 2 embryos obtained. One blastocyst that was released and transferred in another body. She's a gynecologist. It's okay, or should he make a U-turn? I think he used all what's available. He used adjuvants, which may increase the pregnancy rate. He used combined oral contraceptive pills in and use more follicular synchronization. He used the recombinant proposal gonadotropin. However, this has never been validated in a previous meta-analysis, and also by the last issue recommendation, which stated that both are comparable. He added a recombinant LH, which may improve the androgenic milieu of the ovary. However, this is not recommended by the antagonist. The antagonist in this woman has the chance of providing the gynecologist was with double stimulation later on in the luteal phase, and double stimulation has been found to be to yield a more oocyte than the single stimulation. This is the last chapter, the last chapter in the story of the unfortunate missus to do what's called genetic testing to exclude FSH polymorphism. She accepted, but asked him, please, my dear, and then if it is positive. The gynecologist didn't answer, but stated that no answer, it means an answer. The last chapter, should he make a U-turn at this situation? Personally, I think that he did his best, and he says that I did everything I could for you. But this is the story of the unfortunate Mrs. Susan didn't finish. We have the last chapter, which was tragic actually, and very exciting. On about 4 months ago, she was 30 years old and having infertility 6 years, and unfortunately, she acquired a COVID-19 infection, and she admitted for the isolation hospital for about 2 months, and she had 3 swabs, all were positive, but fortunately, the last one was negative. And before discharge from the hospital, she suffered of colic abdominal pain, which is associated with vaginal bleeding, and her gynecologist examined her and find this very exciting finding. Okay, she was pregnant spontaneously in twin pregnancy, and both are viable. This is the end story of the fortunate Mrs. Suzanne. And always remember, if you don't have a last term, the gut can do it, and never measure your gut unlimited power by your limited expectations and understanding. And thank you.
Thank you very much, dear Professor Salah, for a very difficult, very interesting, very provocative presentation. We could discuss some of the items till next year. So while the vote is thank you very much. While the vote is being done, what is the indication of laparoscopy in unexplained infertility? Is there still indication for laparoscopy?
You're asking me, great Prof?
Yes, you, and then Professor Casper, and then Professor McKenna. Is there an indication for laparoscopy in unexplained infertility? In short,
I'm personally feeling that the adequate history taking and histosylbenzography and transvaginal sonography could replace laparoscopy in the vast majority of women, particularly if the lady having primary infertility. This may be changed to what to some degree if she has secondary infertility, but primary infertility, for me, the laparoscopy has no major role.
Thank you very much, Professor Casper.
Well, it's sort of it's a hard question to just make a generalization about, but I have to say I don't think I've done a laparoscopy in about 3 or 4 years. So I think in most cases a diagnostic laparoscopy is definitely not going to change your management. So if it's not going to change management, there's no sense doing it. I think if you have a definite case of endometriosis that has or fibroids where you can't access the ovaries easily, there may be an indication for laparoscopy and surgery, but I don't think there's any place anymore for a diagnostic laparoscopy without treatment.
Salah, can you stop sharing slides, please? Professor McCann?
Yes, the same story is actually true in Brussels. We almost don't plan the diagnostic hysteroscopies anymore because they are of very little added value on top of the IVF ICSI treatment. So when we plan it, it is most often in case of severe pain for endometriosis patients, but not that much to increase the outcome of our IVF ICSI treatments.
Thank you very much.
I'm sorry, Dr. Hassan. I'm sorry, Dr. Hassan. I'm just, I want a comment from Dr. McKean about the study that was terminated prematurely about the endometrial scratching, which was associated with a very high rate of miscarriage. I just want to hear her comment about their findings and why the study was terminated.
Yes, so I will talk about it in my next presentation. We will go more into detail into the study. But indeed, we actually wanted to... Can you hear me?
Yes, of course.
Yes. So actually, we wanted to replicate...
Yes,
so actually, we wanted to replicate the findings of Zhu et al. A paper from 2008, in which they saw very nice results of the in-cycle endometrial scratch. However, we were quite worried that it might be too invasive. And that was why the sample size was calculated to account for 2 interim analyses to safeguard the safety of the intervention. We already had a trend in the first preliminary analysis, and then in the second interim analysis, the miscarriage rate became significantly higher in the intervention group. So that is why the trial was truncated, because we were very concerned on the safety of the intervention.
What do you think about the reason for very high miscarriage rate? Okay, the last one, please.
Yes, I really think it might be too invasive. So what we also did was to check, because we had inclusion of patients having transferred. The scratch was always done between the 6th and the 8th day of the cycle. And then, of course, some patients, they were stimulated longer. Some had a day 3 embryo transfer, other a day 5. So we checked whether the timing interval between the scratch and the actual embryo transfer made a difference, but we could not confirm that trend. But in the end, I think that we probably harmed the endometrium by doing the scratch. So we were very hopeful, but indeed the safety was not guaranteed, and we stopped the trial. Before the trial, we also, for example, performed, sometimes not on a routine basis, but sometimes we performed hysteroscopy with an endometrial biopsy to rule out chronic endometritis early within the cycle. But after the study, we don't do that anymore because we're afraid that we might decrease the outcomes.
Thank you very much. Salah, can you comment on your poll, please? We had the voting, and you can read the questions and answer, please. Quickly, Salah.
Yeah, the first option of patient with unexplained infertility, as stated by Dr. Prof and by me, in young women, it should be expectant treatment, and more than 2/3 of the attendee answered it's okay. The second is routine laparoscopy is recommended for young patients without a pelvic pathology, and the answer is so great. Nearly all the attendee selected the correct answer. The last one, the third question is hysteroscopy is an integral investigation before IVF. No, okay, it's not an integral investigation, and more than 2/3 of the answered correctly.
Thank you very much, Salah. Thank you very much for an excellent presentation and for an excellent voting.